Welcome everyone to today's online expert talk by Doctors Without Borders, Médecins Sans Frontières. Our topic today is malnutrition in South Sudan and Somalia, a medical emergency. Now, before we talk about this and I open the stage for our honored guest to speak, a few administrative things. So I welcome all participants in Zoom and all those who are following also via the live stream on YouTube. In Zoom, we offer simultaneous translation into German. So please select your preferred language through the globe on the bottom line of your Zoom screen. And all those who are following us on YouTube are welcome to dial into Zoom to follow the webinar in German as well, if you want to. So I guess the registration link will be posted in the chat for you. A short note also, we will be recording this session and it will be available later on YouTube. So you can watch it again later if you want, or send it around if you think it might interest somebody else. So you can ask questions via the Zoom and the YouTube chat throughout the conversation, and we will try to answer to all of them in the second part of this webinar. And also, if there's any technical problem or general comment as well, you may just send us a message via chat. So I am Elisa de Siqueira and work as Humanitarian Advocacy Officer on the climate crisis at Doctors Without Borders, Médecins Sans Frontières. So Médecins Sans Frontières is the French name, and we will be using the French acronym throughout this conversation. So it is MSF for Médecins Sans Frontières. So I am based in Berlin. I'm dialing here in from Berlin, while our expert is currently based in Nairobi. So I am very, very glad to welcome my distinguished colleague and expert, Mitchell Sangma, on this panel. So Mitchell is a doctor from India and holds a postgraduate degree in international public health from the University of Queensland in Australia. He has been working for MSF since 2011. As a public health specialist, he has been involved in a wide range of health programs in Uganda, Syria, Jordan, Ethiopia, Nigeria, Bangladesh, and Myanmar, among a few others. And he is currently supporting the projects in South Sudan, and Somalia as a health consultant based in Nairobi. So today's topic is on the malnutrition crises in South Sudan and Somalia. South Sudan and Somalia are particularly vulnerable to malnutrition for various reasons. Somalia and Somaliland are currently experiencing their worst drought in decades, in another below average rainy season. On the contrary, in South Sudan, for the fourth year in a row, widespread flooding has had disastrous impact on the country. People have lost their livestock and crops in both countries. Many people were being forced to flee their villages and their homes. And while they seek refuge in displaced people camps, oftentimes, while they encounter a situation where there's not enough clean water, sanitation, and food for everyone. There are outbreaks of infectious diseases, such as malaria or cholera, depending on the locality. And yes, the malnutrition rates keep on rising. So now, Mitchell, I will be handing over to you. Many of the people in the audience might know already, but just for the sake of clarification, could you tell us what distinguishes malnutrition from hunger, actually, and what exactly is malnutrition?
Thank you, Alisa. A very warm greeting from Nairobi. I think this is a very important question for us to start our conversation on this very important topic of malnutrition, crisis which is looming in the region in the Horn of Africa. Malnutrition and hunger, they often go hand in hand, but they're not the same. Everybody can feel hungry, Elisa, like you and me, like when we are hungry, that is a body signal that tells you that your body needs food when the stomach is empty. And when we eat, we feel satisfied, and then the hunger goes away. Maybe just to note that our body needs nutrients for us to grow and live, and our body gets these nutrients from the different food that we eat. But malnutrition, on the other hand, maybe in a very simple definition, can be defined as a condition of the body when the body does not get sufficient nutrients, or there's an imbalance between the nutrients. Some can be malnourished for a short or long time, called as acute or chronic. Some can be moderate or severe. People who are malnourished They often get sick because their immune systems are weak, will be underweight, and the growth, especially among the children, may be stunted. That means that the height of the children affected, their height might be less as compared to the peers, or the average peers of the same age. In extreme conditions, malnutrition will also cause that. In the context where we work, most often malnutrition is simply because of lack of food. And that is a state that we call as food insecurity.
Well, thank you. Mitch, I don't know, maybe it is my audio, but I'm hearing a little echo when you speak with your microphone. I don't know if you, sorry, if you can, I don't know, adapt sometimes maybe on the computer. Or use a headphone as well. Yeah, that's.
Let me just try headphone.
Yeah, because it would be a pity if we couldn't, listen to you with all your experience that you can share here with us today. So that was a great introduction already into the topic, and I think now it would be interesting for us to go into the two country contexts. So first of all, what is the current situation in South Sudan? And what would you see as the main reasons for malnutrition in South Sudan? Thank you.
Well, to start with, MSF has a very long-standing presence in South Sudan. If my memory serves me right, I think we have a presence in the country since 1984, when the country was still a part of then Sudan. And we know that the association between food insecurity and South Sudan is not a recent event. The country has faced food insecurity crisis throughout its 12 years of independence. But what we are seeing now is unprecedented. The country is experiencing the most serious food crisis of the last decade, with 54% of the population, approximately around 6.6 million people, facing high acute food insecurity. Last year alone, across our different MSF projects in South Sudan, we treat more than 5,500 patients for malnutrition. This is up from 4,500 patients that we saw in 2021, a 20% increase in 1 year. And this has been the trend when we look at all our data for the last 3 years. So yes, what we're seeing right now, it's deeply concerning. But however, it's also important to be clear that in South Sudan, across our project locations, we're seeing a mixed picture in relation to food insecurity in our project areas. In some places, we are seeing a highly concerning level of malnutrition. In other projects, yet we are not yet seeing the high level of malnutrition, though the drivers are there. But in some projects, I think it's also fair to say that we have been able to avert the crisis in a part because of our effort to fill gaps outside of our usual activities, such as early detection of the cases and including the food distributions. And what's driving this malnutrition? Like I mentioned earlier, there are different multi-factors for causing malnutrition. But in the context of South Sudan, I think we can first talk about conflict and displacement. In fact, conflict is considered the main drivers of food insecurity in South Sudan because of the recurrent period of violence, which is common in South Sudan. Communities are forced to flee their homes and take shelters and reliefs in camps. Some hide in swamp for days, for months. They lost access to cultivated fields, and markets and livelihood are destroyed. In some extreme events of violence, we have also seen the entire warehouse in some project locations where humanitarian aids or stores are looted, as well as targeted attack on the health and nutrition centers, which are systematically looted. And when the fighting stops, it's difficult for the people to return home after having lost everything. Houses are often burned and their animals are already stolen. So this recurrent cycle of violence dramatically decreased the resilience of the already stretched populations. And of course, there is also the impact of extreme climate events, like what you mentioned, with consecutive years of flooding and erosions of livelihood. Last year, South Sudan faced its 4th consecutive years of extreme flooding, the worst flood of the last 60 years, according to the many reports. Over 1 million people have been directly affected by the floods. Floods have washed away the precious crops and killed livestock, and displaced hundreds of thousands of people from their home. The floods have led to the expansion of wetlands. Large areas remain submerged even during the dry season. And we're also seeing the change in the trend of the disease pattern, like for example, malaria. Like before, we used to see the increased cases of malaria only during the wet season, but now because of this expansion of wetlands, we're also seeing malaria now also in the dry season. All this destroy the seasonal livelihood opportunities, such as cattle grazing and planting crops, are no longer an option for the people living in flood-affected areas, as the land available for farming has been reduced. Hundreds of thousands of people have been pushed into absolute poverty, increasing the level of malnutrition. And with conflict, displacement, and flooding, disease outbreaks have also become very common. South Sudan is already known to have a very poor health system with limited health centers and hospitals, and also have one of the worst health indicators in the world, especially infant and maternal mortality rates. And with malaria, diarrhea, and respiratory tract infections like pneumonia, which are the leading cause of death among children under 5 in South Sudan. And with nutrition, the malnourished children are far more susceptible to these diseases, especially for infectious disease like measles, and where vaccination coverage is already very low. And important to mention here that under this background of the flood, of the displacement, and with the outbreak of disease, there has also been decrease in the aid funding by the governments, the UN agencies, and humanitarian organizations. First, the humanitarian response to the food crisis that we are seeing now has been and remain wholly inadequate and ineffective for the magnitude of the crisis. And despite this desperate situations, there has been a massive cut in humanitarian aid at a time when exact opposite should have happened. Last year in April, the Health Food Fund, which is the largest donor financing mechanism for healthcare in South Sudan, slashed its budget by 24%. The funding cuts impacted, as we know, more than 200 health facilities and more than 100 nutrition sites. And also the World Food Program funding has been cut by a third, from 900 million to 600 million USD. As a result, food ration has been cut by 50% in some locations and have ceased completely in others. Although malnutrition in South Sudan has many root causes, like what I mentioned, but we also cannot deny that there are also responsibility on the parts of donor countries. So in summary, I think with the recent decline in food security and high prevalence of malnutrition is linked to the combinations of drivers, including conflict, extreme weather events, and spiraling cost of living conditions such as food and fuel. And at the same time, there has been a decline in the funding for the humanitarian program, despite the rise in the humanitarian needs.
That's quite a situation. And for the climate part, at least, I know that for the fact that the water is not receding in some areas in South Sudan, that means that while there is the flooding, the people can't even recover from one crisis before the next wave hits, in the sense. And yeah, that's really just much more a pity that, not only a pity, it's really a shame that the humanitarian funding has been cut. So thank you very much for giving us this insight. And now maybe we want to look at the context in Somalia, because that is quite different, but we also see a lot of malnutrition cases there. You will tell us a little bit more about that. But so to see how it looks like currently, the malnutrition crisis in Somalia, we will be watching a video from Dr. Asma Awais, who tells us a little bit on the current situation in Somalia. So please, DJ, the video.
We are seeing in our facilities patients with different needs, with infectious diseases, with malnutrition, with cholera. So we are responding to many different basic health issues that the community now are facing. I remember that we admitted a mother and her child. The child is admitted into the ITFC program in Bay Regional Hospital. with malnutrition, and the mother is admitted in our pediatric with measles. So the child died 2 days after the admission, and the mother also died in our facility 1 day after her child's death. It was a tragedy to the whole family that were 4 when they came and lost 2 of them, and because of measles and malnutrition needs. The most striking part of treating or running this malnutrition response is that when you see 900 plus cases in a week and also find that 80% of them are admitted to the program, this really tells you the level of the malnutrition in the community, especially in the children. And it tells you also how the population are suffering from food insecurity and the drought as well.
So, Mitchell, what else can you tell us? And what do you believe are the reasons for malnutrition in Somalia compared to South Sudan?
Yes, indeed. That's a very sad story that we heard from Dr. Asma. But unfortunately, this is only one of the hundreds of stories that we hear every day from the patients that comes to our hospital. And these are the patients who makes it into our hospital. And we fear the worst for the patients who cannot come or cannot have access to our hospital. Again, when we look at Somalia, when we look at the bigger picture, I'm afraid that I have to begin with a very sad narrative. In Somalia, massive scale of humanitarian crisis is unfolding. We are seeing the worst drought in the last 70 years. To highlight, in terms of numbers, more than 7.8 million people in various locations across the country needs humanitarian assistance as the rain failed for the 4th consecutive season, with the forecast of the 5th failure. This has already displaced 1.6 Somalis since last year, and more people are expected to flee in the coming months. And in Somalia, insecurity remains a key issue as well. Many places are difficult to access, where people may be severely affected by drought and where disease outbreak and malnutrition are extremely likely. Data collection is a massive challenge in the country, and it's very difficult to get an overview of what's happening in the remote areas. But assumption could be made that the situation in remote or inaccessible areas is even worse than what we see in the areas where we have the presence, and which is already extremely concerning. The malnutrition our team are seeing is also compounded by deadly outbreaks of infectious disease such as measles, cholera, Hep E, and polio outbreaks. As people find refuge in overcrowding living conditions in hundreds of informal shelters and sites all across the town or outskirts of the town, with poor water and for the drinking and sanitation services. All this contribute to spread of waterborne diseases, and outbreak in return increase the risks of malnutrition. The country, what we are seeing now, is struck by an erratic cycle of drought, conflict, and disease outbreak. The affected community barely have time to recover from one crisis before another hits. And that's sadly what we are seeing at this moment.
Yes, and we really see this vicious circle, seeing also the people leaving Somalia, right, going into the neighboring countries, but also inside the countries to other places because they can't stay anymore in their homes. So it's quite a big crisis, and we actually at MSF call it a malnutrition crisis. What are the characteristics of this health crisis? What do you think?
Malnutrition is a part of a bigger problem. In many areas of concern of high food insecurity, there is also a poor health system with basic challenge of access to healthcare, and with the low vaccination coverage to some extent because of the rippling effect of the pandemic, when many of the vaccination programs were halted for the last 2 years, along with the poor living conditions, especially in temporary camps where displaced people are sheltered, often with inadequate safe drinking water and with poor sanitation. All this will increase the risks of disease outbreak. And malnourished children with these diseases have a high risk of dying. All potentially can cause a very high mortality in the affected community. So these are like the characteristics when we speak of malnutrition crisis.
All right, and you did touch upon that already, but I just wanted to see if you can deep dive a little bit more into that. What are the main challenges do you see in this crisis? And maybe also you did touch upon that already as well, but also the climate crisis impact that you see. How does that link to the malnutrition crisis? Thank you.
Yeah. Let me just give the two extreme examples of flood in South Sudan and drought in Somalia related with the impact of extreme climate event. With the ongoing drought in one of our project locations in Baidoa in Southwest State in Somalia, between January and August last year, we saw more than 200,000 people arriving into this town called Baidoa. This is in addition to the approximately 600,000 people already living in the city. After the capital Mogadishu, Baidoa now hosts the second largest number of displaced people. And it has been more than 10 months since we started the emergency nutrition interventions. The number of malnourished children admitted in our program is not going down. We are admitting on an average 600 to 800 massive number of malnourished children in our program since last year. And half of those are severely malnourished. And it's good to note that the vaccination coverage among those children admitted in our program, more than 80% of them have never been vaccinated. And till now, we have admitted and treated more than close to 14,000 children in our program. And as we were very busy responding to this nutrition crisis, we started seeing the suspected cases of measles cases coming into our hospital. The number kept on increasing. And during the peak, we were seeing around 200, 300 measles cases with a very high mortality rate. We responded by opening measles isolation ward. And since last year, we have admitted over 5,500 children till now. And eventually, but yes, in the first phase, we were focused on treating the measles cases, but eventually we had to organize and support a mass vaccination campaign targeting the whole town, including the host population. This brings down the number of the measles for some time, but with ongoing arrivals of the new influx, we continue to see these measles cases again. Many of the sick children we treat in our facilities are also older than 5 years, and most of them are all newcomers, the new arrivals. And as we were already busy and extremely thin on resources supporting the regular hospital with our activities, responding to the nutrition crisis and responding to the measles outbreak, we also started seeing the suspected cases of cholera coming into our hospital, into our supported hospital. And eventually, cholera outbreak was declared in Baidoa last year in April, and affecting hundreds of thousands of displaced people, including the host population as well. Cholera, which is a contagious waterborne disease, affect the most vulnerable communities, and children are 3 times more likely to die from it. And between May and August, we recorded around more than 14,000 suspected cholera cases in our mobile clinic, and we admit around more than 1,000 suspected cholera cases in our treatment center. And we have to go outside of our normal routine because by this time, it was not enough just to treat the cholera, to treat the measles. So in order to prevent the disease spread, we have to go outside of our normal activities and start supporting in preventive activities. We carried out water trucking, chlorinizations for drinking water, and we started supporting in drinking water to improve access to clean waters. We ended up building hundreds of latrines, conducted health promotions activities in the community, and distributed essential hygiene items such as soaps and jerrycan to the community. Now from drought, let's move to our experience with flood in South Sudan. Taking example of our MSF experience in Bentu in the Unity State, there's a displaced camp which hosts the largest IDP camp in South Sudan with about more than 100,000 people. But in September 2021, approximately 45,000 people arrived, having fled their village because they have totally become submerged by water. They started staying in a makeshift camp within the displaced camp without access to drinking water or sanitation and without humanitarian aid, especially food. And at this time, WFP the World Food Program cut food ration to 50% in this IDP camp and reduced its blanket supplementary feeding program from reaching all children under 5 to just reaching children under 2 years. With reduced food rations for the IDPs in this town, people have to rely on a small and insufficient quantity of food to sustain themselves and their family. Families sometimes have to share quantities among a large group of people, meaning a reduced food proportion for each member. Around this time, admission in our malnutrition center increased by 80% during that period. MSF at the time was already expanding our nutrition beds capacity. We kept on expanding, but yet the facility continued to operate beyond excess capacity. And at its peak, I think around April, May last year, we were already admitting more than 100,000 children per month with severe acute malnutrition, the highest level ever recorded since 2019. So coming back to the question, so irrespective of the extreme flood or drought, we are seeing the impact of extreme of climate in many of our project locations and affecting the already stretched community.
Thank you, Mitchell. And then what I thought is really interesting as well is how when children are malnourished, their immune system is down, and so they are more at risk for other diseases, as you said, in Somalia, for measles or for cholera. I guess in South Sudan, there was a moment also where hepatitis E was spreading, right? And also related to the floodings and the sanitation situation. So maybe can we go a little bit more into the concrete activities of MSF? Maybe you can share a personal story of some of our patients or of colleagues of yours, how they work to fight against malnutrition, and how do we treat malnutrition?
Well, to start with, MSF has a huge expertise in treating malnutrition. Over the years, we have acquired experience in responding to malnutrition in different settings, and we have developed medical protocols and training programs to support our staff so that we'll be able to deal with different type of malnutritions. And now we are also working towards simplifying our program so that the nutrition program can even be decentralized to the community level as well. In response to the malnutrition crisis, in many of our project locations in Somalia and also in South Sudan, we have increased the bed capacity in many of our health centers. We started going out from our hospital to set up a community program to treat less complicated malnutrition, which can be managed at home. We have started investing in what we call as a engagement with the community to understand their concern, and also to get a feedback on what would be the community mitigation or localized measure for them to prevent this crisis. And this has been very, very effective for us to understand and for us to support in this process. And not just that, but we have also started integrating the nutritional screening in all our health programs. For example, like if the pregnant mother comes to our hospital, we've also started screening the pregnant mother and also the child. And we have started integrating and in programs like HIV and TB. When the HIV and TB patients are diagnosed, we also screen them for malnutrition. So we started strengthening our nutrition surveillance, like from the health centers to the community. Like we started collecting the information on the price of the food just to keep on track, to see whether the condition is worsening. We started documenting the movement of the people that is coming in so that we'll be able to react faster. And in preparation for this crisis, we have started pre-positioning the therapeutic food that is needed to treat the malnutrition in many of our project locations, including pre-positioning medical supplies and training to our health staff. And above all, we have remained flexible and dynamic in different approach, adapting the context-specific program. So those are some of the activities that we have stepped up as a response to this malnutrition crisis. And the stories that we hear from our patients, or the stories that our team hear from our patients, that has been very sad stories indeed. I remember one particular story from one of our project locations, where a mother has to travel for 8 hours carrying 2 malnourished children. And unfortunately, the 2 of them died by the time they reach our nutrition centers. So it was very painful. And like I mentioned, and like what Dr. Asma also mentioned, like these are like one of the very sad stories that we hear quite often. And yes, so it's very difficult for the team as well. Like, it's not just about the treatment part of it, but also the human side of it, that when we hear such stories, like how do we support them? So we also started engaging in providing psychosocial support for the affected community, so that they can cope better and develop resilience in such critical situations.
Well, indeed, that is a very sad story, and so good to hear that there's also the psychological support that the MSF teams can give in those projects. So, well, to our audience, I have one last question I want to ask Mitchell, but before I do that, just to tell you, if you want to know anything specifically on Mitchell's work, on South Sudan and Somalia, on malnutrition in general, please send us your questions in the chat so we can discuss with you and respond to your questions later. So, Mitchell, I see with all that you told us here that there's still a lot that has to be done, and the MSF is already trying to respond to the crisis in a lot of locations, but as you also pointed out, there are other responsibles, people that are responsible. For instance, the government that should be providing humanitarian aid as well. And so what else can we do about this situation, or what can maybe political decision makers do? Is there anything MSF would advocate for in these two specific contexts? Because you well mentioned as well that they are quite different and specific contexts.
So I think the important message is that we cannot do it alone as MSF. So we need all the humanitarian actors to step up, maybe based on our conversations, based on what I've said earlier, that for South Sudan, the humanitarian response to the food crisis has been and remained wholly inadequate and ineffective for the magnitude of the crisis. And despite this desperate situation facing the population, there has been a budget cut, which has, of course, has an impact on the overall response to this crisis. And so, although like malnutrition in South Sudan has many deep root causes, like what I mentioned earlier with conflict, with the extreme weather event, but it cannot be denied that there are responsibility on the part of the donors countries. So we, as MSF, we are calling for an urgent scale up of the humanitarian and health assistance to the community worst affected by food insecurity and malnutrition. For Somalia, to respond to a massive scale of drought that we are witnessing right now, a coordinated humanitarian response of all actors is needed. More transparency across humanitarian community about specific operating challenge. The current response is not enough. There's more need for more funding, more response capacity, and programmatic support is needed. And it's also very crucial to step up. Yes, it's very crucial to step up the nutritional program, the nutrition program, including prevention and treatment program, but there's also a need to scale up and integrate the nutrition program with health and vaccination program. So we cannot only remain focused on nutrition program when there is a link between the malnutrition with different disease outbreak. And the programs need to be adapted to the context specific. We need to move away from one size fits all strategy. For example, giving the example of the measles outbreak in Baidoa in Somalia, when the measles hit, with the measles outbreak, we did advocate for the measles vaccination campaign, but because of this one size fits all strategy, we could only vaccinate the children under 5 years. But we know from our data that even the children more than all has 15 years, they were all affected and we were advocating for all the children to be vaccinated. But because of this one-size-fits strategy, we couldn't do it. So these are some of the examples that how we should be using the evidence-based data in order to respond to the context-specific response. And this is what is needed. Like we need a tailored program, and they need a coordination with all the actors, including the developmental actors, including including developmental actors, and including the actors supporting the livelihood. So we need a coordinated effort.
Yeah, I think that's a very powerful message. There's no one-size-fits-all strategy for treating different individual patients, basically. We have already a first question that came in from the audience, and maybe if I ask this question, then the others will be more courageous to ask other questions or to give us a comment in the chat if you want. So, I mean, you touched upon it a little bit already, but still, besides malnutrition, what are other major concerns in the medical programs you have in both countries?
Yes, like I mentioned earlier, that malnutrition doesn't occur in vacuum. Like, for example, like in Somalia, like we are focused on the mother and child hospital. So we were supporting with the normal deliveries, with the normal sexual and reproductive health programs, supporting with the pediatric ward. And malnutrition was not one of the components that we were engaging, because there were other actors who were already supporting the nutrition program. But as the crisis started, we started seeing the other organizations supporting the malnutrition program getting very overwhelmed. We started seeing lots of community deaths in many of the camps where we have our presence. So we have to step up. We have to move away from our regular normal activities to be able to respond to the crisis. And in South Sudan, we have a very comprehensive health programs across the different project locations. Of course, like we also tailor based on the context and we try to work in partnership with the other organizations, including the government. So whenever one organization is supporting with the primary healthcare, then we tend to support the hospital care. So it's all based on the context, but we basically we try to support with different level of needs based on the gaps, starting from primary healthcare to the hospitals. In some of the hospitals that we have, we even have the operation or theater support, the OT surgical programs. We are supporting with transversal programs like HIV, TB, sexual gender-based violence, and we have also started investing a lot in the last recent years in the community programs, because we understand that not everyone can come to the hospital, and only the people come to the hospital when they're already very sick. So we started investing in developing the community program, in trying to get the community participations in preventions, including the treatment itself. In some contexts, we train the community health workers from the village itself for them to be able to diagnose and treat a very simple disease like malaria, diarrhea, and some skin disease, including the respiratory tract infections, which has been the major killers, especially among the children under 5 years. So we have been adapting and responding based on the gaps and based on the needs. But yes, we have learned, we have come a long way since I think and the program has been evolving from time to time.
As you were talking about the communal health workers, would they be able also to treat non-severe malnutrition?
In some areas,
what is needed exactly to treat malnutrition? Maybe.
No, I think that's a very important question, because when we talk about the malnutrition, like whenever we have the picture of a very malnourished children in the hospital, like very thin and very weak. Yes, those are the very extreme cases for which you need to be admitted in the hospital. But if the malnutrition can be detected early, when they are not severe, when they're still moderate, that means they still have an appetite, they can still eat. At this stage, yes, we have also been able to treat the patients, the malnutrition patients in the community. That means we will give them therapeutic feed and give them the supply for a week, and then when they finish the supply, we will ask them to come back. But it has also been a challenge, especially with the crisis when there is a food insecurity. That means we have a very high admission rate. That means the children admitted are admitted in our program. We cure them and then we discharge them. But going back to the environment where there is no food, then they become malnourished again, and then they come back to us. So this has been a regular challenge when there is general lack of food in the community. We have also seen the children that sharing the therapeutic food which we give for one children, but of course, when we give to one child, when they go back home, there will be other siblings who also are hungry, but they are not malnourished. But the mothers will also have to share with them, which is a very human thing to do. But then again, this child for whom we have given the therapeutic feed will not be able to gain the necessary weight because the child will be receiving inadequate feed. So these are some of the common examples that we regularly see in the community where we work.
Yeah, here's another question from the chat. How's the security level for the medical staff, local and international, in Somalia and South Sudan?
Yes, I mean, for us to do our work, we need to ensure that our staff can work safely. So the security has always been a very big, important consideration for us. Like I said, like our focus is on our focus is to support the community. So we have a very good engagement, that we have a proximity with the community that we serve. So we have a good acceptance because we come in as an organization, as a neutral organization that is helping the community. So usually, because of the proximity, because of our work, because of our because of the work that we do, we usually have a good acceptance in the community for us to carry our work.
Yeah, that's super interesting. There's another quite personal question. That is, how did you start to work with MSF? Was malnutrition always a topic for you, or did you also work on other health crises or on other diseases?
We're working with MSF for the last 10 years now. Yes, working in different contexts, but yes, malnutrition has always been one of the programs where we often see, not just in Somalia or in South Sudan, but also in different contexts. Like I mentioned, for instance, like in South Sudan, we have been treating malnutrition since the time when we started our program. So yes, we have integrated malnutrition into all our existing projects because based on the gaps that we see and based on the needs that's there on the ground. So yes, I have work in different contexts and work in different health programs, including from vertical HIV/TB programs to responding to the emergencies, such as in Bangladesh or in Nigeria. So there has been a different context and different designing of the health programs, but the core strategy of wherever I'm based has always been based on the needs, and the design of the program has always been based on the context. So that makes it a very valuable experience, that it's not just like, yes, the treatment of malnutrition might be similar, but the way you design the program, it's very different from one context to another. And it has been an experience being able to work in different contexts.
And we are always talking about there's no one size fits all strategy, but then there's one question here which I thought was interesting. If there's other countries where you participated maybe in the treatment of malnutrition as well, which are maybe comparable to the contexts in South Sudan and Somalia, if you can say so?
Yes, well, I think it's a very important opportunity for me to highlight that the malnutrition crisis, and like for this conversation, we have focused mostly on Somalia and South Sudan. But this crisis is not just limited to these two countries. We are seeing the deepening crisis especially in this horn of Africa, including parts of Kenya, in Ethiopia, and in Sudan, and across the countries across the Sahel belt. For example, like in Sudan, where I'm also operationally supporting the country, like yes, there's been different drivers of malnutrition, but in the end, yes, we are also seeing the similar trend with the increased rise in the number of malnourished children. Just to highlight a very good example, like in one of our project locations in Sudan, like we have a hospital, like we have a malnutrition ward, but we are not seeing any malnutrition children coming to us. And we were thinking that, okay, like, like the village or the community has not been affected so much in spite of the drivers of malnutrition, like the food increase, like the fuel increase, like the failed rainy season. Then we started going out to the community. Then we started doing we did what we call as a rapid nutrition assessment, when our team goes into the community. But of course, it was a very difficult terrain. We had to travel by donkeys, to walk, to reach to the different villages. So we just targeted around 40 villages just to see the different level of malnutrition. And the results, what we found was very alarming. The malnutrition rate was very high in that community. But people have also started accepting that malnutrition is a part of the common living. So, and they didn't see that malnutrition children should be going to the hospital. So they were mostly linking it to the food, to the availability of food, which they think they will not be able to get from the hospital. So we have to adapt. So we started opening up the community program. So we started forming the mobile team to go out into this nutrition into the community for us to be able to screen and treat those children. So yes, just giving that as an example. Like sometimes we may not see it, but yes, sometimes only when we start looking for it, then we find it.
Yeah, thank you. Here's a quite critical question in the chat. Do you think the world leaders, politicians, and organizations are sufficiently aware of the major humanitarian crisis in Somalia and South Sudan? And what about MSF? Is there enough internal awareness and commitment? What would you say?
I think as an organization, right now, we are talking about what we are seeing on the ground. And that's our focus, like irrespective of the media attentions but what we are doing right now is we are stepping up in different countries where we are seeing this crisis, adapting different programs to be able to respond. So yes, we do share our what we find, especially like with the important partners, and we have been advocating for the organizations, for the other partners to step up. Like I said and mentioned before, that we all need to be together in this, and has MSF, like we cannot do it alone. So yes, I think that's important that we talk about what we are seeing on the ground. And yes, our focus has been on responding to the massive crisis that we are seeing.
And as you said before, also there are the strong advocacy messages that we have and that we try to engage with international decision makers as well. Oh, we have a very nice comment in the chat now that I would like to share with you, Mitchell, which is, thank you and all the best for your fantastic work. Very good presentation.
Well, thank you. That's a very encouraging work. So
yeah, and maybe to stay on this positive note, I don't know if you might want to share a story from one of your patients, maybe share with us something that gives you hope in the work, something that makes you stay, because you're working for MSF since 2011, so there has to be something.
Well, yes, I think that's a very beautiful question. Yes, like maybe when I say this, I think I'm also speaking on behalf of many of the colleagues who are there on the field. Like, yes, it's not easy for us to, to hear these painful stories, to see the crisis and also the frustration that sometimes we feel that we're not doing enough when more needs to be done. So that's all very common. But at the end of the day, I think that we also feel that, personally, I feel that the work that we do have a huge impact, at least as we try, on the people that we have been able to reach to. So maybe just one example that I remember, that's just in my mind right now. Many years ago, when I was in the field, when I was a doctor in the field, as a doctor, you have to do all type of care. You're not going in as just a doctor that you'll be focused only on adult care. But once you are there, you have to treat the children. You have to take care of the pregnant mother as well, and also go out to the communities do the health education or health health talks with the communities. So in one of the projects where I was based, there was a very pregnant mother who came in a very let's say in an advanced stage, and who had a very difficult pregnancy and labor. So yes, we supported the mother, and eventually she had a very healthy delivery. And of course, she was sick, so we treated her, and I was one of the doctor, part of the team who treated her. But what I learned after from some of my local colleagues that the mother was so happy with the work that with the support that she received, that she named her child that was born there after me. So I think that's one of the very good story that I will always remember.
Wow, that's a really, really nice story. I remember another one as well from a pediatrician who was in South Sudan as well. I think it was in Bentiu. And he was working while a woman came in who was pregnant with twins. And I think she had to walk for several hours as well to get to the hospital. And when she arrived, everybody was really afraid that something would go amiss. But then in the end, the two children, the two babies and the mother were healthy in the end, and everything went fine. So I guess that is really really great when you have these moments where you know that you actually make a difference and you can save lives. So that is really great. Well, I guess we are coming to an end of our session. And so I would like to thank you very much, Mitchell, for sharing your valuable experience, for being here with us. And also thank you very much to the audience to be here, to have participated, to have asked questions. And if you want to know more about MSF's work on malnutrition and other health emergencies, you can just visit our website and register for our newsletter if you want. I think the links will be posted in the chat very soon. And also we offer regularly other events on various humanitarian and medical topics about working for MSF too, to work as Mitchell and work with us maybe for the next 10 or 15 years. So you're very welcome to have a look at that. And then also, if you feel like supporting MSF any further, we always welcome donations as well. You can find the details for donations on our website too. And I guess there will be another link shared in the chat as well. Mitchell, do you want to say something for the end? Do you have the final word?
No, thank you very much. Thank you very much for inviting me to share our experience on what we are seeing here on the ground. Like I said, what we are seeing now, it's unprecedented. But I think it's also very equally important, for us to be able to share what we are seeing now with the wider community, because we need the support. Like I mentioned earlier, and we need the support from especially and we also need to advocate on and to speak. I think the world needs to know what's happening here in Somalia and in South Sudan. So I think That's very important. So thank you for giving this platform, for sharing, for letting me share our experiences.
Thanks a lot, Mitchell. And thank you all for listening. We will close down the Zoom webinar now, and please stay in touch. If you want, you can send the YouTube link to other people who might be interested. You can always chat with us through the YouTube link or via the contact email addresses that we have on the website as well. And yeah, it was really great to have you all with us today. Thanks a lot.
Thank you.